to sensitize the student in MD medicine and DNB medicine so that they get a fair idea of how to handle the cases in rheumatology. So the first lecture today is being taken by Dr. Gayatri Ekbote. The topic is Approach to Arthritis. Dr. Gayatri is a consultant rheumatologist in Dinanath Mangeshkar Hospital and Research Center, Pune, and she has her own hospital, Ekbote Hospital. So over to you, Gayatri, to start with your topic.
Good morning, everybody. Thank you for such a nice introduction, sir. So I would like to thank Maharashtra Rheumatology Association, first of all, because we all have been medicine students first, and then we got into the specialty of rheumatology. And I always feel that rheumatology is a subspecialty of internal medicine. And if it's not medicine, then we really cannot proceed to rheumatology. So basically, as you all can see these diagrams, one would have thought that arthritis just means joint inflammation, but that's not the case. So today we'll be having a case-based approach a little bit. So the idea is to share the basic principles of rheumatology. So first lecture is on approach to arthritis. So I mean, I'll go through case scenario and then go through the basics of arthritis. So in between, if you feel like, I mean, you can ask questions in the chat box, and later probably we can take questions after once my lecture is over. So coming to today's topic. I'm not able to. Hello, can you hear me, sir?
Yes, ma'am.
It's hung probably. 1 second. I'm not able to actually proceed forward. There's some issue.
Ma'am, are you using Windows or a MacBook?
Mine is MacBook. Sorry, Windows. Microsoft.
Okay. Click F5.
Okay, I can now. Can you see this slide, case capsule?
Yes, yes.
Yes, yes,
Yeah, thank
yes.
you. Okay, so this is a case of, I mean, this is, recently there is this 20-year-old male who came to us from Nagar, which was formerly known as Nagar. So he basically came to us with history of polyarthritis, which actually means pain and swelling of multiple joints, which included small joints of hands, wrist, elbows, and knee since last 7 years. With obviously, since it's an inflammatory joint, in inflammatory arthritis, he had excessive early morning stiffness, which was more than half an hour, for which he was evaluated there locally, and his rheumatoid factor and anti-CCP antibody were strong positive. So basically, he was treated with steroids and NSAIDs for a while for symptom control and for inflammation control. So on further evaluation, when we received him, he just didn't have an arthritis. He also had kind of anasarca. He had swelling over the face, both legs, and then he had worsening of joint symptoms because his steroids and NSAIDs were stopped, and that was worsening since last 2 months. When we evaluated him further, he also gave the history of excessive fatigue, photosensitive skin rash, and oral ulcers, which were painless. That's why they were unnoticed. So on examination, he was vitally stable, afebrile, but he did have pallor. He was anemic. He had periorbital edema and pitting over both lower limbs. His JVP was not raised, so he was not in failure. Other systems were normal, grossly. So if you could see, these are his joints. So you can see the proper rheumatoid arthritis deformity, which is ulnar deviation of both the hands. So on examination, his multiple large and small joints were inflamed. So radiological examination, when we did his X-ray both hands, there were joint erosions and joint deformities, as you can see, obviously. So basically you can see joint erosions, joint space narrowing, and then some soft tissue swelling around the joints. So when we evaluated him further, he definitely had anemia. He had acute kidney injury that was probably drug induced or his disease induced. We don't know yet. His potassium, he had hyperkalemia to start with. His albumin was quite low. His urine RM, urine routine microscopy showed 3 plus albumin and there were RBC casts. He also had multiple pus cells. So his 24-hour urine for protein did show nephrotic range proteinuria, which was 3.7 gram per 24 hour. So basically, we have a 20-year-old male from Nagar, who was diagnosed to have rheumatoid arthritis very rightly based on inflammatory systemic chronic polyarthritis, and he also had rheumatoid factor and anti-CCP positivity. But he came to us with history of new onset mucocutaneous involvement, anemia, nephrotic range proteinuria with RBCs in urine and with deranged kidney functions. Probably everything was going towards glomerulonephritis. So obviously this is not a simple inflammatory arthritis case, or this is not a simple case of rheumatoid arthritis. So now coming to the differentials, obviously, yes, we know that RA does exist in this patient because he is fulfilling the EULAR ACR criteria of rheumatoid arthritis. I'll be coming to that later. So what could be the differential diagnosis? So do we really have proteinuria in rheumatoid arthritis? Yes, it can happen, but it is quite rare. But per se, we do not get glomerulonephritis or photosensitive skin rash and oral ulcers or just mucocutaneous ulcer just because of rheumatoid arthritis. Yes, methotrexate or toxicity or other drug toxicity can lead to some mucositis, but proper oral ulcers is very rare in rheumatoid arthritis. Can some drugs cause proteinuria, rheumatoid arthritis related drugs? Yes, there were few drugs like gold, etc. But it's very, I mean, these drugs are not used these days. Oral ulcers could be because of drugs. Then amyloidosis, that was one of the possibilities. But again, you cannot see glomerulonephritis, photosensitive skin rash, oral ulcers in amyloidosis, RA with amyloidosis. So now what are we left with? Yes, definitely we are dealing something which is not simple. So do we have an overlap of another connective tissue disease? Yes. So overlap CTD, yes, that was one of the that was the most important possibilities thought here. Because he had proteinuria, RBC cast, photosensitive skin rash, and oral ulcers. So further evaluation, his ANA was strong positive. His ANA blot or ENA showed positivity for dsDNA, nucleosome, histone, etc. Obviously, we got his renal biopsy done and that showed class 4 lupus nephritis. Okay. So interesting case, right? Isn't it? So this is quite an interesting case. So what is it? What we are dealing with? So if you can see nicely, so you can see the immunoglobulin deposition with some complement deposition in the kidney biopsy report. And what is class 4 lupus nephritis? So this is diffuse proliferative glomerulonephritis. So patient basically had both rheumatoid arthritis and lupus nephritis. So this kidney biopsy is typically suggestive of a full house pattern with immunoglobulin deposition with wire looping. Okay, so basically patient also had DPGN class 4 lupus nephritis. So does our patient fulfill the criteria of SLE as well? Yes, he does, because he had acute cutaneous lupus, oral ulcers, arthritis, and renal involvement. And most importantly, his ANA was strong positive and his anti-dsDNA was also strong positive. So he is also fulfilling our SLIC criteria for SLE. So what is the diagnosis then? So I want to remind you all that rheumatology is a branch of exclusion. So there is always a classification criteria for all the diseases you have. Rarely, there are only 2-3 diseases when we actually have a diagnostic criteria, because you have to rule out multiple conditions before you really go into the diagnosis of rheumatological disease. So basically, our patient was fulfilling criteria for both the diseases, rheumatoid arthritis, because he had symptoms of inflammatory arthritis. He did have erosive arthritis and his RF and anti-CCP were strong positive. He also was fulfilling criteria of SLE, which I just shared, and he had class 4 lupus nephritis on renal biopsy. So now what is the final diagnosis? So this is definitely an overlap syndrome of RA and SLE, which is fondly known as lupus. Not fondly for the patient, but probably for us for academic purpose. So patient had lupus, which is an overlap connective tissue disease. So let's just come to the management so far. We started him on hydroxychloroquine. We gave him methylprednisolone pulse for 3 days, followed by prednisolone tablet in tapering dose. We counseled him because he was not financially very well. So he did opt for him and his parents opt for cyclophosphamide, which was given as NIH monthly pulse. So far, he has received 2 pulses. Then ACE inhibitors were started once his renal functions and potassium started improving and when they became normal. And obviously was started on calcium D3 because he's going to need steroids for really long and then other supportive treatment. So he's received so far 2 cycles of cyclophosphamide. He's doing much well symptomatically. His hemoglobin has improved, creatinine is improving, albumin is improving, and his urine routine is showing a good improvement. So this is about a case scenario, and this is a real life case, obviously. So you all can see that rheumatology is not just it's not just about arthritis. So this definition, so rheumatoid arthritis is also is one of the connective tissue diseases. So CTDs are multisystem diseases that share several common clinical features with strong immunologic underpinning. And this definition is by our very own Dr. Handa sir. Also, Dr. Helen has told us, which I just described, that arthritis just does not mean joint inflammation. So we have more than 200 diseases which can have arthritis, but other systemic complaints also. And it's not just affection of joints, but there is an affection of tissues that surround joints and other connective tissue disease. So basically, arthritis is a super inflammatory condition, and you can have variety of systemic involvement. So now, so basic 5 to 6 questions we ask when patients of rheumatoid arthritis or patient of any joint pain comes to us. So we have to ask basically whether it is an articular pain or non-articular pain, whether it is really arising from joints or no. Is it acute, less than or equal to 6 weeks duration, or chronic duration? Is it inflammatory or mechanical? So this is my favorite question when I take classes for UG or PG students. So we all know the 5 signs of inflammation, and we have to see whether that patient is fitting into that inflammatory joint pain or no. Then you have to look at the pattern of joint involvement, which is very important when you have actually reached to a diagnosis of inflammatory arthritis. So you have to see whether small joints are involved, large joints are involved, is it axial or it is appendicular pain, etc. And then the most important part, which I said, is other associated symptoms, because obviously we are internist first. So you have to look at the systemic involvement as well. So this is just a simple diagram of your large joint, any large joint. So as you can see, joint is not just made up of 2 bones. You have the bones, then you have synovial, you have the articular cartilage, you have synovial cavity, you have bursa surrounding it, then you have joint capsule, you have tendon, muscles, tendons, and then entheses. So joint is made up of so many different things. Okay, so articular pain is just there throughout, whether you do active movement or passive movement. Whereas non-articular pain is that arises mainly from your tendons, bursae, muscles, fascia, bones, or nerves, or skin. And non-articular pain is mainly on active motion and not on passive motion. In articular pain, there is there is very bad pain. So there is a lot of limited range of motion. But in non-articular involvement, there could be just a focal tenderness. Swelling could be present in non-articular, but that's because it's a sign of inflammation. We see more in articular pain. And deformities, usually you get to see from a pain arising from articular thing. So we have variety of non-articular conditions which can mimic your inflammatory arthritis, and these are very common. So you get to see such patients in your day-to-day OPD, or these are referred by your ortho colleagues, etc. So obviously in shoulder you have rotator cuff tear, frozen shoulder, bursitis. Then in elbow you have famous medial lateral epicondylitis or tennis elbow, olecranon bursitis. Because of overuse injury or because of certain infections, you can have tenosynovitis. Diabetic patients can have diabetic karyoarthropathy or trigger fingers. Then in knee, you have variety of conditions which can lead to knee pain. Then similar conditions can be seen in hip, ankle, and foot pain. Now, the most important question which you have to ask first yourself, and obviously then you can proceed further, whether it's an inflammatory pain or non-inflammatory pain. So we all know the signs of inflammation. So basically inflammatory pain is AM pain, because as soon as patient gets up in the morning, he feels pain because of the impaired lymphatic drainage by your inflammation, because of your inflammation. Whereas non-inflammatory pain is usually your wear and tear pain. So whenever, as the day progresses, you must have seen your grandparents at home. As the day progresses, you have a lot of pain arising because of the degenerative changes. As I've mentioned earlier, you will have signs of inflammation in inflammatory pain, which is swelling, erythema, warm, excessive morning stiffness, and other systemic features like weight loss or fever, appetite loss, etc. ESR, CRP, which are our famous inflammatory markers, will be raised very oftenly in inflammatory joint pain, and synovial fluid will often be inflammatory. So these all features will be typically absent in non-inflammatory joint pain. So you have multiple conditions which can lead to an inflammatory arthritis. So as I said, rheumatology is a branch of exclusion. You have to rule out multiple other things till the time you reach your proper immune mediated arthritis conditions. So infection, yes, very common in India. Crystal arthropathy like gout, CPPD arthritis are very common. Reactive arthritis. So reactive arthritis is something which happens post infections, and obviously immune mediator or vasculitis associated arthritis, these are commonly seen in our day-to-day practice. Non-inflammatory conditions which are common are degenerative or osteoarthritis conditions. So osteoarthritis is a misnomer. Though it has an itis, it is not really an inflammatory arthritis like your rheumatoid arthritis. Then you have overuse tendinitis or bursitis. Then you can have trauma-related joint pain. Then there are certain neoplasms like PVNS which can mimic your inflammatory arthritis conditions. Then the most important condition, especially in corporate hospitals, is fibromyalgia or metabolic causes like thyroid conditions, parathyroid conditions, diabetic. So they can have joint pains, body aches, etc. But when we actually examine them, these patients will definitely lack the signs of inflammation. Okay. Now, this is the history taking is exactly like your undergrad program. So, as I mentioned earlier, you have to ask about the duration, whether it is acute or chronic, pattern of joint involvement, whether it is intermittent, continuous, because most of the times gout is such a condition where you get intermittent arthritis, whereas your prototype of chronic inflammatory polyarthritis, rheumatoid arthritis, by definition, it is continuous or added involvement. Then the most favorite question of undergrad or postgrad students is aggravating and relieving factor. So basically they'll tell you that the inflammatory joint pains will be relieved initially by doing some work, or I mean as the day progresses. But obviously once the joint pain becomes too bad, they'll have relief with NSAID, steroids, etc. Early morning stiffness, I explained about that. Whether it is an axial involvement or appendicular involvement, so especially we know about the spondyloarthropathy. So there is an inflammatory back pain and patients have alternate buttock pains. Okay. Then associated swellings noticed by patients. Drugs history, you have to ask them whether they are taking any treatment for themselves, or and then you have to rule out drugs causing arthritis. I'll be coming to that later. To rule out infection-induced arthritis or reactive arthritis, you have to ask basically the history of fever or any recent infection. Arthritis is again very common in IV drug abusers. So you have to ask that history as well. So just coming to the pattern of joint involvement, basically mono by definition means arthritis of a single joint. Okay. So mono acute, that means the duration of a single joint inflammatory arthritis, which is less than or equal to 6 weeks, less than 6 weeks. Infection, yes, very common, septic arthritis. Then you have gout, pseudo gout, and reactive arthritis, and then other inflammatory conditions. And non-articular mono-articular pain, if patient has a lot of joint pain, you have to rule out trauma, fracture, reflex sympathetic dystrophy, etc. Oligoarthritis means the involvement of 2 or 3 joints, and the chronic and monoarthritis, as I said, it is an inflammation of a single joints. So in chronic mono or oligoarthritis, you have few differentials. So just let's understand non-inflammatory conditions first, because these are much more common. I mean, at least osteoarthritis, AVN, etc. Then diabetic patients can have neuropathic arthritis. Then there are few miscellaneous conditions like hemochromatosis, PVNS. Inflammatory arthritis with just mono or oligoarthritis. The differentials are psoriatic arthritis, your spondyloarthropathy, indolent infections or reactive arthritis like your Ponset disease. Then in children, when you have arthritis which comes before 16 years of age, you can have enthesitis related arthritis, which could be polyarticular, and pseudogout, because pseudogout can involve more, 2 or 3 joints as well. Polyarthritis. So in adults, poly actually means more than or equal to 4 joints. So in acute polyarthritis, you have few differentials, which I've mentioned here. And in chronic, you have the prototype of chronic polyarthritis is your rheumatoid arthritis. Osteoarthritis can sometimes be inflammatory when you have inflammatory osteoarthritis, but chronic inflammatory polyarthritis prototype is generally your rheumatoid arthritis, and then you have other differentials as well. So just remember the first case which I discussed, the young male who had rheumatoid arthritis. He was fulfilling the criteria of rheumatoid arthritis as well. If you all remember, if you all can go back to that case, he definitely had inflammatory arthritis with RFCCP being positive, and then his ESR CRP were raised, and he had symptoms which were more than 6 months. So now this is again, as I said, this is a classification criteria, and you have to look at the score. So if the score is more than or equal to 6, patient has definite RA. But again, in this case, you have to rule out multiple other conditions to label patients as rheumatoid arthritis. So this is just a nice hand diagram. You all can see a single hand can be a differential for so many joint conditions. So wrist involvement is very commonly seen in your rheumatoid arthritis. Your CPPD, your crystal arthropathy or pseudogout can have wrist involvement. Gonococcal arthritis, especially in males. Then you have to ask history of exposure, etc. JIA, juvenile arthritis, and then carpal tunnel syndrome, which is very commonly seen in medicine or neurology OPD. Carpal tunnel syndrome is not just associated with your rheumatoid arthritis, but it can be seen in your hypothyroidism, pregnancy, etc. MCP joint involvement is very peculiar for your rheumatoid arthritis, but in rare cases, pseudogout or hemochromatosis can also have metacarpophalangeal.
सर मैंने ईयरफोन नहीं लगाया नो नो म्यूट पता नहीं है
Who is Madhu? Could you please mute yourself? Yeah. So PIP involvement is very commonly seen in rheumatoid arthritis, psoriatic arthritis, etc. By definition, and this is a favorite MCQ for all students, by definition, rheumatoid arthritis spares DIP. So distal interphalangeal joint involvement could be seen in psoriatic arthritis, sarcoidosis, multicentric reticular histiocytosis, or osteoarthritis, etc. Osteoarthritis, first CMC-OA is very common, and decurvent stenosynovitis, there are variety of conditions which can lead to decurvent stenosynovitis. So now coming to predominantly lower limb involvement. So as I said, you have to ask the history of axial involvement also in these people. Rheumatoid arthritis by definition should affect small joints first, but obviously it can, small joints of hands first, but it can obviously affect feet joints as well. So the predominantly lower limb involvement is seen in your spondyloarthropathy, reactive arthritis, osteoarthritis, and sarcoidosis. If you all can remember your definition of sarcoidosis, sarcoidosis is obviously mainly a lymphadenopathy with lung involvement. So as you all can see, you have to ask for this systemic complaints as well. Intermittent arthritis, something which comes and goes. So in between you can have a honeymoon period. Most important intermittent arthritis is your gout. Okay, so patient will tell you that they have the episodes of gout. That episode is quite painful. Patients have excruciating pain. It does resolve by taking colchicine, NSAIDs or steroids. In between they are fine, but they can get the repeated attacks. Then there is an entity which is known as palindromic rheumatism, and it has variety of conditions. So palindromic rheumatoid arthritis is one of them. So their rheumatoid factor or anti-CCP could be positive, but arthritis is intermittent. So later they can have proper inflammatory polyarthritis, which turns into your proper rheumatoid arthritis. Migratory arthritis. So whenever you are appearing for your viva, obviously these definitions are asked, the difference between intermittent arthritis, migratory arthritis, and your fleeting arthritis, etc. So your rheumatic fever, which we do not see so commonly nowadays, but yes, acute rheumatic fever can have migratory arthritis. There is a fleeting joint pain. So you have a single joint involvement one day, next day it can proceed to another joint, and it is inflammatory. Okay. Then other differentials are bacterial endocarditis. You have to look for high-grade fever, any cardiac symptoms or rashes, typically of and infective endocarditis. And SLE can also have migratory arthritis. So as I said, this is probably our most favorite part, because when you ask this question, you have come to almost the end of the history. You have to ask for aggravating and relieving factor, whether patient and whether the morning stiffness that gets relieved by these by doing these things or no. So inflammatory arthritis, as I said, it worsens with rest because inflammatory fluid being accumulated because of the rest. It decreases with activity. It gets better with NSAIDs and steroids. Sorry for that arrow. How do you differentiate rheumatoid arthritis pain from osteoarthritis pain? Because patients can have overlap of both arthritis. So generally osteoarthritis pain is a wear and tear pain, and the morning stiffness is lesser as compared to rheumatoid arthritis. Especially in ankylosing spondylitis, patients can have alternate buttock pains. So as soon as, once they go for sleep, probably 2 to 3 hours later, they have to get up in the night because of pain, because of the inflammation. So coming to axial involvement, the differentials for axial involvement causing arthritis are your ankylosing spondylitis, psoriatic spondyloarthropathy, reactive arthritis, enteropathic arthritis associated with Crohn's or your ulcerative colitis, brucella arthritis. Again, you have to ask history of unpasteurized milk consumption, etc. Rheumatoid arthritis very rarely can lead to axial involvement, but if at all, it can lead to cervical involvement. There can be an atlantoaxial dislocation, and that's not a very good thing to have, because that can lead to paraplegia if not treated on time. So, as I said, we see this condition known as fibromyalgia mostly in corporate hospitals. Obviously, you can see them in government hospitals as well. But basically, if patient denies any inflammatory condition, if you cannot see any inflammation when you examine the patient, you have to either rule out whether it is treatment modified arthritis or it is just a fibromyalgia. So you have to ask history particularly. So these are the drugs which can lead to drug-induced arthritis. So this is a very famous or favorite topic of our undergrads and postgrads. So there is this MCQ which is asked always, the drugs causing drug-induced lupus, and you all know antihistone antibody is positive in this condition. So you have ship drugs like sulfa drugs, isoniazid, hydralazine, procainamide, etc. These all can lead to drug-induced lupus. And then there are multiple drugs which can lead to other types of arthritis, like your pyrazinamide, the very common AKT which is used, that can lead to hyperuricemia, and in turn can lead to gout. Obviously, alcohol is one of the most important causes for gout. You can have osteonecrosis because of steroids, alcohols, bisphosphonates. Then scleroderma could be because of pentazocine, tryptophan, organic solvents. So you have multiple drugs which can lead to multiple conditions. So glucocorticoids could be double-edged sword. They treat the patients, but if you do not use them in right quantity for right time, they can cause drug-induced myopathy or avascular necrosis, etc. Quinolones, protease inhibitors, your ARTs, they are very much notorious to cause joint pains or tendinitis, etc. So basically, you have to look at the drugs also which patients are taking. Now, the most important part is systemic symptoms. So obviously now you've dealt with the joint thing. Now you have to come to the systemic complaints. You have to ask whether patient has any fever or no. They'll say that I have fever, but then you have to ask which kind of fever patient has. Is it a high grade fever or not? Whether patient had chills associated or no, etc. Then you have to ask about the history of rash. Rash is very common in all the rheumatological conditions. So adult onset still this is typically characterized by arthritis, rash and fever. Then your SLE, dermatomyositis, they have typical rash, which is photosensitive skin rash. I'll be coming to that later. Then these bacteria can also lead to fever, rash with arthritis and multiple viruses. You all have seen chikungunya arthritis last year. We are hoping that it should not come this year. Okay, so you have seen that typical chikungunya maculopapular rash with arthritis with the preceded by fever and then serum sickness condition. So the most important part is whether reactive arthritis has any fever. So generally by definition, reactive arthritis does not have fever at the onset of arthritis. So they will have fever preceded. I mean the fever will be much before arthritis would have come. So you have for these conditions like for reactive arthritis, septic arthritis, enteropathic arthritis or even for bacterial endocarditis, you have to ask for history of IB drug abuse, any preceding loose stools, etc. So basically, you all must have understood the history taking in rheumatology is exactly similar to your medicine history taking. Now, extraarticular manifestations, mucocutaneous involvement. So this is arthritis with erythema nodosum. You can see the erythema nodosum rashes. These I have put a lower limb picture. So these EN rashes usually come in crops. So the common differentials are your sarcoidosis, COX. Post-streptococcal arthritis is much common. It's more common than sarcoidosis. Lupus can have erythema nodosum, and your enteropathic arthritis like Crohn's or ulcerative colitis can also have EN rashes. These are extremely tender erythematous, and they have elevated appearance. When you biopsy them, you will see paniculitis. So paniculitis is basically an inflammation of subcutaneous fat. So this is your keratoderma blennorhizicum. So you have involvement of GUT and hands as well. This can be seen in reactive. This is seen usually in your reactive arthritis. So this is your typical psoriatic rash. So psoriasis could be a long case for you all guys. So you have multiple types of psoriatic rashes. So this is a typical plaque psoriasis. So you will get to see these rashes in your medicine ward. If not, please go and visit your dermatology wards. You will see variety of psoriatic rashes there. So this is typical plaque psoriasis. So this is white lacy rash. So this is important viva question. So you have multiple types of psoriasis, plaque psoriasis, which I just showed. Then you have nail changes with psoriasis, matted psoriasis. You all know this because of your MCQs. These are small water droplet shapes like psoriatic rashes, usually triggered by bacterial infection. Which bacteria is homework for you all? Please read. We'll ask this question in the next class. Inverse psoriasis. The psoriasis is seen usually in the hidden areas which we often miss. So this could be in armpits, in buttocks, behind the ears, etc. or around the genitals, around the breast. Then pustular psoriasis. Erythroderma psoriasis is not a very good form of psoriasis that can actually lead to skin failure if not treated. Then obviously psoriatic arthritis. Because we are dealing with arthritis, we have to talk about psoriatic arthritis. So psoriatic arthritis is very important. So you have different domains of psoriatic arthritis. You do have nail lesions, then you have dactylitis, which is involvement of the whole digit, then enthesitis. In the beginning of my presentation, I've told you what is enthesis. So enthesis is when there is when the tendon attaches to your bone. So the inflammation of that part is known as enthesitis. Then you have axial disease, skin involvement, as I said, and peripheral arthritis, which could be in the form of knee, ankle, or other joints. So this is Mole and Wright classification of psoriatic arthritis. This is exclusively from Harrison. This is not from rheumatology textbook. That means obviously if it is there in the Harrison, it can be asked in your question. So you have multiple type. I mean, there is a classification of psoriatic arthritis. You have asymmetric oligoarthritis, symmetrical polyarthritis, which can actually mimic your rheumatoid arthritis. That's why you have to take history properly. DIP arthritis is commonly seen in psoriatic arthritis, which is DIP involvement is not common in rheumatoid arthritis. Then you can have spondyloarthropathy in psoriasis, psoriatic arthritis as well. Arthritis mutinus actually when you have extensive bone destruction. So this is your vasculitic skin rash. So you can see there is petechial purpuric skin rashes. These are non-blanching. If you try and press them, they do not blanch. So these are typical vasculitic rashes. This is arthritis. This is your palatal ulcer, hard palate ulcer. So usually whenever you have CTD, the ulcers are not painful. That's why they are not noticed. So the common differentials of arthritis with oral ulcers are SLE, Crohn's, Behçet, etc. So as I told earlier, can you all tell me what is it? So this is dermatomyositis skin rash. You can see the heliotropic periorbital edema. You can see the macular skin rash. Okay, so this is typically dermatomyositis rash. So you have gotten papules, gotten macules, etc. Ocular involvement is very, very common in rheumatological conditions and very important for us. So uveitis can have underlying spondyloarthropathy, sarcoidosis, GPA, Behçet disease. Conjunctivitis could be commonly seen in your lupus, Sjogren syndrome, GPA. Scleritis, again, a sinister part of eye involvement could be seen in your small vessel vasculitis, rheumatoid arthritis. Ischemic optic neuritis is usually associated with your large vessel vasculitis, or it could be associated with your GPA, etc. So you all can see scleritis and episcleritis. The question is often asked is what is scleritis, what is episcleritis, what is uveitis. So that is for all you to read. We'll have definitely a lecture on eye involvement in rheumatology as well. So IBD, UC versus CD. So we have been reading about UC and CD since our patho days. We all know the difference between the UC and CD, but inflammatory bowel disease can lead to inflammatory arthritis as well because of the gut and joint interaction. So you can have chronic remitting intestinal inflammation, which can in turn lead to your inflammatory arthritis. So this is a difference between ulcerative colitis and Crohn's disease. We all know the difference between that. I'll not get into the details of that. So this is just about inflammatory arthritis. So you can have large joint involvement, axial involvement. You can have osteoporosis because of vitamin D calcium deficiency, as well as because of the excessive steroid abuse. Then other things like extra intestinal manifestations. These many extra intestinal manifestations could be seen in your IBD, inflammatory bowel disease. This could be a viva question, or this could be your theory question. So please read about it. Now, coming to the features which point out to actual CTDs. So the connective tissue disease, your Harrison mentions was famous 6 CTDs. So Raynaud's phenomenon, as we all know, Raynaud's is a triphasic phenomenon. So you have initial white discoloration, then you have bluish discoloration, then there is compensatory erythema. And if it is not treated, if it is not picked up early, patients can have pitting scars, digital ulcers, and in the worst cases, they can have gangrene and autoamputation. Okay, they can even have acro-osteolysis. So nail fold changes. If you have the capillary in your wards, in your medicine department, please learn. So the dropouts and hemorrhages are the last part of your Raynaud's phenomenon. So when you see these things, that means the Raynaud's or vasculopathy, it has progressed. I have discussed about skin rash of dermatomyositis. So this is a typical skin rash of SLE. These rashes can also be seen in other overlap CTDs or dermatomyositis. So SLE, skin rash, we all know, we all have heard about acute cutaneous lupus, subacute cutaneous lupus, or chronic lupus, which includes your famous BLE. So that does not mean it is acute or chronic in duration. So it depends on the type of the skin rash. So you can see the typical malar skin rash. So here it has almost spared your nasolabial fold. So you have malar rash like SLE. So this is inflammatory photosensitive skin rash. So on sun exposed areas, you have the erythematous rashes. So this is your annular erythema. This is subacute cutaneous lupus. You can see. So these cases you can see in your medicine wards. This is discoid lupus. So this is a part of your chronic lupus erythematosus. So you can see hyperpigmented skin rashes. Okay. So alopecia again is very common in all rheumatological conditions. Non-scarring alopecia is very common in lupus. The beauty of this alopecia that it gets reversed with the treatment. And vasculitic skin rash, I've told you about it. So this is dependent skin rash, non-blanching, and it could be seen in your variety of conditions like Sjogren's, rheumatoid vasculitis, small vessel vasculitis, polyarthritis nodosa, etc. Or your HSP, Henoch-Leuwen purpura. You have to rule out obviously infections. So Goton papules, heliotrope rash, sclerodactyly. So the most favorite question of examiner is the differential of telangiectasias. Obviously, when you are appearing for your medicine viva, if you say that telangiectasia are commonly seen in scleroderma, you will not be given the marks which you deserve. So the most important differential is always your chronic liver disease, which you have to remember. Obviously, if patient has accompanying features of like sclerodactyly or other dermatomyositis, etc., then probably this telangiectasia, these point out towards your CTD. But always remember, first things first. Oral ulcers, I've told you about. Obviously, these are painless most of the times. That's why they do not get noticed very early. These are usually on the hard palate. So that's why you have to examine these patients. So Sjogren's syndrome or other CTDs with secondary Sjogren's can have a lot of sicca because of whatever their oral hygiene is compromised. That's why they can have lots of caries also, and they can have fungal infections, candida in mouth. So you have to see all these things. So this is oral thrush, which we typically seen in Sjogren's syndrome because of excessive dryness of mouth. Ocular dryness and oral dryness. Ocular dryness, the most important bedside test is your Schirmer's test. You can learn that from your ophthalmology colleagues. Obviously, arthritis I have dealt with. Now, I hope after this class, you have to catch patients and treat them at this point. Acute arthritis can be a forerunner of rheumatoid arthritis or your SLE, early synovitis. We don't want our patients now to progress to these particular conditions. Jacob's arthropathy, these are the reversible deformities, whereas RA deformities are not reversible. So this is usually seen with your SLE, etc. Other features like inflammatory myositis, serositis, which you see commonly in your wards, pleural effusion, ascites, edema, lymphadenopathy, cytopenias, raised ESR-CRP, positive ANA blot or ENA, low complements. The most important feature here has to be positive ANA if you have to call it as connective tissue disease. But few myositis may not have ANA anti-nuclear antibody positivity. They can have cytoplasmic antibody positivity. The most important part here is close differentials of CTD. So you have to always rule out infections first, in India at least. So rule out COX, viral infections, fungal infection, infective endocarditis, mostly lymphomas, solid organ tumors, then drugs, as I discussed about that before. So now, as you must have understood, the history taking is quite similar to your undergrad and postgrad medicine. This is a busy slide. We'll have class later about the investigations in rheumatology. So how and each antibody in your ENA or ANA blot helps for the diagnosis. So now often question asked is what is UCTD, what is overlap CTD, what is MCTD? So I would say these are cousins of each other. So overlap CTD, like in our first case, patient had actually, he was fulfilling criteria of two different diseases, whereas MCTD you can have features from each of these connective tissue disease, but most important part here is UN1 RNP positivity, whereas UCTD is something which is half-baked. It has not progressed to a proper disease, but it has one or two features from each disease. So other systemic symptoms, obviously you have to ask is cough. weight loss, appetite loss, shortness of breath, hearing loss, tingling, numbness, bloody diarrhea, muscle weakness, parotid enlargement. Particularly, you can have when you have something which is worst, which is one of the worst forms of CTDs, are ANCA vasculitis. They can have hemoptysis, hearing loss, neuropathy. Then you have to ask all these questions we have discussed about bloody diarrhea, or even vasculitis with intestinal involvement, or SLE enteritis can have diarrhea. So you have to ask about all these systemic complaints. Other history: fatigue, altered sleep pattern, irritability, history of any blood transfusion, any surgery, any procedure recently done, etc. Because these all things can have miscellaneous arthritis, or fibromyalgia can be one of the DDs for your inflammatory arthritis. So at the end of the history, 70% diagnosis has to be clear, okay? At least whenever you take history in your medicine wards or in OPD. Examination, it should be done on the bed initially and then look for the gait. Rheumatoid arthritis has this important thing which is known as DAS28, where you calculate disease activity, but it does not include your feet joints or ankle joints, but you can include ankles as well whenever you see the patient. So the examination is like your usual systemic examination. You have to do inspection, then you have to look at the asymmetry, swelling, deformities, atrophy, erythema. Then you have to look at range of motion on, you have to look for active range of motion, passive range of motion. You have to see for the pain, crepitus, any popping, any abnormal movements. Okay. Then palpation, when you palpate the structure, you need to know the anatomy of the structure you are palpating. You have to look for the swelling, warmth. So you all have learnt about palpation in your surgery postings. So you have to palpate each areas then that's why then you will evaluate it further. And then obviously you have to compare it to your, if one wrist is swollen and another wrist is not swollen, you have to always compare. So this diagram is again from your Davidson. So as you all must have understood by now that rheumatology is not just joint. Obviously, you have to start from head to toe. So you have to look for all the organ involvement. So as I said, rheumatology does not spare any specific organ. So you can have alopecia, skin involvement, you can have uveitis, conjunctivitis, you can have nasal bridge collapse, epistaxis in vasculitis like ANCA vasculitis. You can have certain conditions like relapsing polychondritis, which can even involve your pinna. Nail involvement is quite common in your psoriatic arthritis. Vasculitic rashes, we have discussed about. Lymph node is very common in all CTDs. The neurological examination is again very important, especially when you have a patient who also has myopathy or peripheral neuropathy or carpal tunnel syndrome. For abdomen, you have to look for serositis like ascites. Most of SLE patients can have hepatosplenomegaly if they have autoimmune hemolytic anemia. Then again, respiratory involvement is very common. Most of the RA patients will have your interstitial lung disease. Sarcoidosis will have your diffuse pulmonary lung disease. Then you can hear crepes, bronchi, etc. Then pleurisy, pleural effusion is very common in other CTDs as well. Aortitis, AR, these are very common in Takayasu arthritis. Cardiomyopathies again are seen in CTDs like SLE. Infective endocarditis, as I said, not just Libman's. Libman's could be associated with SLE or your Apla syndrome, but proper say infective endocarditis is you have to rule out infective endocarditis before you reach a diagnosis of CTD. Then pericardial effusion could be a part of your serositis. So others like other things I discussed about nails. You not just in psoriatic, but IBD and Whipple's can have onycholysis, clubbing, pitting. Parotid enlargement can be seen in Sjogren's. Macroglycia is associated with amyloidosis. Tophi, you can see actual tophi in gout. Telangiectasias, as I said, it is obviously seen in CLD, but you have to look for scleroderma. Dactylitis could be a part of spondyloarthropathy. So this is dactylitis. So you can see the whole digit is swollen and it's not just a single joint. So this is feet dactylitis. This is hand dactylitis. So literally the shape is like sausage. So these are also called as sausage fingers. Those who eat non-veg will understand what I'm saying. So at the end of history and clinical examination, 90% diagnosis is made. That's why we have taken this class today. Now investigation are just 10% supportive. So do not jump to the investigation immediately. You have to order minimum investigations, at least in India. We have, not all the investigations will be cost effective. So these are the basic investigation. Obviously, your CBC, inflammatory markers, CRP could be costly, but in your institute, if you're doing it for like lesser price or for free, you can go ahead. LFTs, RFT along with CBCs are very important. Obviously, if you have to take proper history to order for serology, or if you have to start patient on strong DMARD or immunosuppressive treatment, you have to do these 3 tests. Thyroid, very important. 30%, approximately up to 30% of the rheumatological patients can have thyroid abnormalities. Most of you must be doing must be doing thesis on thyroid involvement in rheumatological conditions. Then obviously you have to rule out diabetes. Chest X-ray is again very important. You have to look for lung involvement and rule out other infections. So these are arthritic specific investigations: rheumatoid factor, anti-CCP, ANA, HLA, ANA blot or ENA, synovial fluid analysis. Nowadays you can even do MSK ultrasound or MRI. So you have to take the history accordingly. Please take your senior's opinion and then order these investigations. Okay. So synovial fluid aspiration, it's very easy to do. Basically, whenever you do synovial fluid aspiration, you have to rule out if it is monoarthritis, acute involvement, or even chronic arthritis. Chronic arthritis, the most important thing you have to rule out, most important thing is to rule out infection, because if you do not rule out infection and if you keep on giving immunosuppressants, obviously patients will worsen. So this is a miscellaneous slide. Arthritis accompanying systemic diseases. These are very rare diseases, but not really rare diseases, sorry. So thyroid diseases, diabetes, other paraneoplastic etiology, these things can also have inflammatory arthritis. So just to conclude today's talk, most important thing is history, then your examination. If you take history properly and examine properly, you can reduce the cost of investigations. Avoid starting patients on steroids or DMARDs. Obviously, in emergency, you can start patients on NSAIDs, DMARDs, if steroids, if their kidney function and other things are normal. But please avoid starting patients on DMARDs or other immunosuppressive treatment until you're really sure about the disease. And stepwise approach is always beneficial. So thank you so much for attending today's class, and I hope this was useful for you all. Any questions you can ask? Deepak, we should take questions.
So anyone wants to ask any questions regarding today's session? Be it a basic, but try to ask so that there are a lot of questions in your mind which should get addressed.
We all hope that many medicine residents have attended this, and if we happen to come for your Viva, we'll be asking these questions. So you better ask questions to us now.
So there is a question: can TB will be a differential of arthritis with erythema nodosum?
Yes, definitely. So what is it called? Who has asked this question?
Dr. Vanraj?
So Dr. Vanraj, are you online?
Yes, yes.
Yeah, so can you unmute yourself? So this is basically an interactive class. Even I want to learn from you all. So I'm quite exhausted after talking for 1 hour. So you tell me, can TB be the DD of arthritis with EN?
Yes, ma'am. It
Yeah.
can
So
be.
what kind of EN you see in COX? So skin involvement in tuberculosis is not just for, not just in rheumatology, but also for your medicine is important. So yes, TB is important DD for EN with arthritis, but then you have to rule out other systemic features like weight loss, appetite loss, history of preceding fever, pulmonary symptoms, etc. Okay. So post-streptococcal, if it is acute, post-streptococcal is the most common cause. Then your COX, sarcoidosis, inflammatory bowel disease, even lupus, these all can have erythema nodosum.
थँक्यू निलेश सर, तुम्ही थांबल्याबद्दल कार्यकर्त्याची वाट पाहत बसले.
Any other questions?
For arthritis patient, how long does it take time rheumatoid patient to start showing erosions or deformities?
Sorry.
It's asking for student purpose. For rheumatoid arthritis patient, how long they take to start showing deformities? Why it is important to diagnose them early?
So by definition, your early arthritis is less than or equal to 2 years, right?
Yes.
So there is no proper time limit for erosions or deformities. Correct me if I'm wrong, Deepak. But if you do not treat them at early stages, so you have few things like polyarticular involvement at the onset, high titer anti-CCP antibody, male gender, history of smoking. So these are poor prognostic markers. So if you do not treat them early, the erosions or deformities could be faster. But by definition, early is something when you diagnose arthritis, early RA, it's something which is less than or equal to 2 years. So if you catch RA, symptomatically, if you catch RA, at that point, probably you can halt deformities and erosions.
Okay. And in acute onset,
1 minute. Deepak, I would interrupt
yes,
you. We have
yes, sir.
separate lectures on rheumatoid SLE,
Yes,
so
sir.
don't take these questions right now. I think
Okay,
Gayatri, you have done an excellent job by
Thank you so
taking
much.
an overview of approach to arthritis. Just to sum up, I would like to mention two things to all the residents, that a strong, thorough knowledge of internal medicine with a proper history taking and examination is the main take home message of this lecture. You need to have proper clinical skills of examination so as not to miss anything in the connective tissue disorders. So it is not just arthritis, so look beyond the joints, and a head to toe examination is absolutely essential in all these cases who are referred to you or if they are admitted in your unit. Just to add one more to the list of infections which you mentioned,
Yes, sir.
leprosy is a very common
Yes.
disease which
Sorry, I
is
missed.
still common. It can present with inflammatory arthritis. It can present with deformities which can mimic RA. So you need to check the patients and take a good history for leprosy as well. And when the deformities have not yet set in, you need to remember a benign condition called as hypermobility of the joints, in which the patient may sometimes present with laxity of ligaments and therefore they may appear with early deformities, but you can actually reduce them when you are doing the clinical examination. So to conclude, diagnosis in cases of arthritis and connective tissue disorder should mainly be clinical, and clinical. And therefore, clinical examination with a very good history taking is very, very important. And this is the most important take home message of this lecture. So we conclude today's session. Our next lecture will be on 24th of August. That is the fourth Sunday of August. The topic will be announced in due time to you. Thank you.
Thank you so much, sir.